one of the problems that we've had in a very fast-moving field of the management of lung cancer is that you tend to see a lot of studies all at once compared to the same standard. And that really makes it difficult often to interpret data. Clearly, the data is now showing that incorporating immunotherapy into the perioperative space is beneficial. I think the main challenge is figuring out how much chemoimmunotherapy to give and whether or not, for instance, adjuvant immunotherapy is necessary in patients who would have received chemoimmunotherapy prior to surgery. And Dr. Lee, in his presentation, argued that if one looks at cross-trial comparisons, you can at least make the argument that continuing with the adjuvant, even in patients who receive neoadjuvant therapy, is beneficial. But of course, the real way to evaluate this would be in a randomized trial, and we just don't have that data to date. I think there is still a bit of a disconnect between the utilization of neoadjuvant chemoimmunotherapy in academic centers versus community practice settings. So at academic centers, there's been a strong push, particularly in patients who will be needing some sort of adjuvant therapy because they have lymph node positive disease, to incorporate chemoimmunotherapy prior to surgery. There are some theoretical reasons to think that would be better than adjuvant therapy, and the data is really quite strong. And so I think that one of the things that would be great coming out of this is if the participants saw the enthusiasm for neoadjuvant chemoimmunotherapy, particularly in patients who will be requiring some sort of systemic therapy.